and the hemoglobin S. You can also do isoelectric focusing, which better separates out some of the more unusual variants, and then high-performance liquid chromatography allows for smaller samples and more rapid results. So some of the other common structural variants that you may see show up. So the hemoglobin S is that glutamine mutation. Hemoglobin E, as I mentioned, it's specifically pointed out in your board content as being an important hemoglobin variant to know about, is common in Southeast Asia. We see it in the thalassemia where patients co-inherit hemoglobin E and beta thalassemia or sickle cell SE disease. Hemoglobin C we've already mentioned. And then there's two other unusual hemoglobin variants, D Punjab and O Arab. I know in Texas, our newborn screen, we screen for D and O because they do occur. They are like the hemoglobin C in that they do modify sickle cell disease. So when you co-inherit SO and SD, you tend to have milder disease. All right, let's talk a little bit about management and treatment in sickle cell disease. So, blood flows everywhere, therefore sickle cell disease has manifestations in every organ system of the body. They have chronic anemia, so you have the consequences of chronic hemolysis with jaundice, risk for gallstone formation. You have acute complications due to either worsened anemia or vaso-occlusion, such as pain, priapism, stroke, acute chest syndrome, and splenic sequestration. And then you have chronic organ damage that results from these recurrent acute complications in both the spleen, the brain, the kidneys, lungs, bones, and eyes. So what are the important components of management of sickle cell disease? So early identification has proven to be one of the main ways in which we prevent disease complications. In the United States, every state screens for sickle cell disease. So you know the little newborn screening cards that are placed. And that allows for early identification and to begin ongoing lifelong education of both the caregiver and the patient as they get older. There are very important prevention and screening things that we do, prophylactic penicillin, immunizations against those bacteria that they're vulnerable to due to the splenic damage, and then screening transcranial Doppler, which I'll talk a little bit more about. We have disease-modifying therapies that are actually FDA approved now, hydroxyurea, the use of chronic transfusions, and stem cell transplantation. I'm not mentioning gene therapy, though that's all that my patients want to talk about, because that is not something that is standard therapy yet. And then we have a variety of methods of managing all the different acute complications that may still occur even on some of the disease-modifying therapies. So hydroxyurea, the mechanism, it's a ribonucleotide reductase inhibitor, and its main action is to induce fetal hemoglobin production. I showed you the hemoglobin curve. You make fetal hemoglobin, and then the gamma globin disappears, and the beta globin goes up, and now you have symptoms of sickle cell disease. So by keeping the fetal hemoglobin high, you can modify the severity of sickle cell disease. It's also overall cytoreductive. If you've ever looked at the CBC of a sickle cell patient who's not on any treatment, you notice they're anemic. They have a very high white count. They often have thrombocytosis because of their overactive marrow. And so we think that the overall cytoreduction also helps prevent some of the disease complications. Vaso-occlusion, if you remember the picture, it's not just that sickled cell that's binding to the endothelium, it's the white cells and the platelets as well. So right now the indication is to start it in patients with SS or S-beta thal null, so our more severe genotypes, offered around 9 months or older. Again, it is now FDA approved, actually for ages 2 and up. The dosing is once daily. We begin at 20 milligrams per kilo. You should dose increase over time to their dose-limiting toxicity dose, which is usually anywhere from 30 to 35 milligrams per kilo. The main reason I see the medication is ineffective is that patients are often left on the same dose for months and years at a time, and therefore they are not on a maximized dose. Primary toxicities are transient, some dose-related neutropenia and thrombocytopenia. You do have to monitor CVCs. There's no apparent risk of increased malignancy. And it's very efficacious. Decreases frequency of pain, acute chest syndrome, hospitalizations, and transfusions, prevents organ damage, and we think that it prolongs life. Our other option that's a disease-modifying therapy is transfusion therapy. These can be episodic or acute. So when a patient presents to the hospital with an acute complication like acute anemia, acute chest syndrome, they're going to have a surgery. We may give them an intermittent transfusion to correct the anemia to stop the process in acute chest syndrome or to prevent them developing acute chest syndrome when they're going to be receiving general anesthesia. Typically, it's just a simple transfusion. We just want to raise their hemoglobin back up if they've become more anemic. We want to avoid over-transfusion. Do not transfuse over a hemoglobin of 10 or crit of 30 because there are some viscosity issues. There are some an acute exchange transfusion would be different. That would be done in acute stroke, severe ACS. If there's multi-organ failure, you have a septic patient in the ICU. Or patients who have relatively high hemoglobin levels that you can't give them enough simple red cell transfusions to decrease their percent hemoglobin S to a safe range to prevent further ongoing sickling. And so this can be done manually or automated using a machine. And then there's patients who may be on chronic transfusions, and so very different process. Primarily, this is for strokes, recurrent acute chest syndrome, and frequent pain. These are often monthly transfusions. They require some type of vascular access. Your goal is to transfuse them so their hemoglobin S is less than 30%. You have to do some extended matching due to the risk of alloimmunization, and sometimes you may do partial or automated exchanges. The main risk with chronic recurrent transfusions is iron overload. Small risk of infection related to their vascular access, and then transfusion-related infections, and then alloimmunization, which is where they develop antibodies against antigens on the donor's red cells that are different than their own, which can make matching blood in the future take longer or more difficult to find a donor. Stem cell transplantation. So right now that is our only curative therapy for sickle cell disease. The main indications for transplant right now have been with patients less than 16 years of age who've had a stroke or impaired neurologic function, recurrent acute chest syndrome, bad sickle lung disease, recurrent painful episodes. They have an HLA-matched sibling donors are limited, and so there are ongoing trials looking at other types of donors. There's some tension in the community about whether patients who are now well controlled on hydroxyurea, should they be transplanted, because we're preventing some of these complications, but they have lifelong need of medical therapy to control their disease. And if they have a sibling for transplant, that still may be a very good option for them for cure. So now we're going to go into the individual organ systems and their complications and then how we manage them. So splenic compensations, they begin about 3 months of age. It's a lifelong risk of bacterial sepsis to encapsulated organisms. It's why we screen them as newborns, because the goal is to get them on prophylactic penicillin by 2 months of age. It's important why we push the importance of immunizations and why we strongly educate parents on the empiric management of fever. Splenic sequestration, as the red blood cells become, so your spleen is in sort of the relatively hypoxic part of your circulation, and so the red blood cells, as they go through the spleen, they sickle. They can cause trapping in the spleen. It can be mild to severe, maybe recurrent. It is actually a life-threatening morbidity associated with sickle cell disease. I had a little girl come in last fall with a hemoglobin of 3.6 with her splenic sequestration. She was not mentating. This was a very acute onset anemia. She was in the ICU. Fortunately, we were able to get her transfused, and she did not have significant untoward complications. We teach parents how to feel the spleen, teach the residents how to feel the spleen, and sometimes splenectomy is needed for patients who have severe recurrent episodes. Fever and risk of sepsis. So we do consider fever a medical emergency, especially in our unvaccinated younger children less than 2 with sickle cell disease. They have functional hypersplenism. The risk of bacterial sepsis is greater than 400 times the regular population. Prompt evaluation, IV antibiotics. There are some patients who we definitely recommend having high-risk features and being observed in the hospital. So high fever over 39, age less than 1 year, recent doses of penicillin missed. My last pneumococcal infection was in a 9-month-old whose family left the penicillin when they went out of town, and she was off penicillin for about a month, and she came in with a pneumococcal infection. Pulmonary infiltrate or respiratory distress, very high white count, history of previous pneumococcal sepsis, or you're not sure the family's going to follow up again, and if they don't have transportation, they can't get back to the clinic for a reevaluation. The blood culture pops back positive after you've already discharged them. There's no way to get them back into clinic. Okay, so now we'll move on to acute anemia. So there are several reasons why patients with sickle cell disease may suddenly become much more anemic than their baseline hemoglobins. So you can have a transient aplastic crisis. This is primarily associated with viral infections. We talk about the parvovirus B19. There are some other viruses that may cause it. So it's any condition which causes them to no longer be able to produce the number of red blood cells that they need to because they have shortened red cell half-life in sickle cell disease. So it's marked by reticulocytopenia. They will have normal platelets. They'll have a near normal white count. And so these patients will often need blood transfusions to support them as they'll become progressively anemic until their marrow has recovery and is able to start producing red cells again. As I previously just mentioned, acute splenic sequestration can also be a cause of sudden acute anemia. These patients may be in shock. They often have a very large, painful spleen. As compared to the aplastic crisis, you're actually going to have an increased retic count because it's not that the marrow is not producing, it's that the blood is being trapped inside the spleen. It also may be accompanied by thrombocytopenia because a big spleen likes to trap everything, not just red blood cells, but your platelets and your white cells too sometimes. Okay, acute painful episodes. This is probably the most common reason that you see sickle cell patients. It is the most common complication that they suffer from. There are most of my older kids will talk about, we know the things that trigger their pain, but sometimes they can't always identify it. Infection, inflammation, cooling of the skin, stress. Sites of pain can be musculoskeletal, abdominal. There are not always physical signs present. Occasionally, you may have some swelling or changes to the site where the pain is happening. We want to identify some of these symptoms early and avoid dehydration, avoid cooling of the skin. So we give kids warnings about going swimming in cold water, wearing warm clothing, not going out when it's cold. You want to avoid overheating. We know we can prevent pain with hydroxyurea, and then there's a newer drug called crizanlizumab, which was, the phase 2 was published in 2016, which was shown to prevent sickle cell pain episodes. So how do we manage pain? We use NSAIDs, we use opioids, we try to individualize it to the patient and family, their age, what they can take. We want to avoid overtreatment. We also want to avoid undertreatment because that can make them have a lot of behaviors that develop because their pain isn't being treated. Nowadays, we're trying to push more non-pharmacologic adjuvants, warm compresses, relaxation, massage, acupuncture, acupressure, yoga, guided imagery, all of those type of things to help them better cope with their pain as opposed to just throwing medications at it alone. We want to correct dehydration. When they're especially hospitalized with pain medication, we want to use incentive spirometry. It was one of the few things we've been shown to be able to prevent acute chest syndrome when you're on opioids and you have opioid-induced hypoventilation. You have vigilance for fever. They will get constipated, and therefore they need laxatives and things to prevent, because that's the worst thing is you get over your pain crisis and then you have such severe constipation, you're stuck in the hospital longer. Oftentimes they need antipyretics. And then typically acute transfusion does not change an acute pain crisis. Because if you remember the pathophysiology, you have vasal occlusion and then you have tissue reperfusion injury. A blood transfusion is not going to get rid of tissue reperfusion injury and pain. It may prevent the next pain crisis, but it's not going to treat the current pain crisis. Acute chest syndrome. So this is an acute pulmonary illness that can happen for a variety of reasons. It's not all infectious. It involves a radiologic density or infiltrate on your chest x-ray, some sort of respiratory signs and symptoms, so tachypnea, difficulty breathing, hypoxia. Fever is not always required for the diagnosis. It's usually not always apparent initially on hospitalization, but again, being in with a pain crisis is one of the greatest risk factors for acute chest syndrome. It can be mild and not need a lot of treatment, or it can be fatal and require ICU care. So we do know that some infections can incite it. So viruses, mycoplasma, chlamydia. We know you can have pulmonary vascular occlusion, you can have pulmonary fat emboli, you can have bronchospasm in patients who have asthmatic disease, pulmonary edema due to overhydration, and anything that causes hypoventilation and atelectasis. So generally anesthesia exposure, laying on your back in bed and not getting around and moving. We tend to treat with empiric antibiotics because it is multifactorial. You will have to do transfusions in patients who have worsening respiratory symptoms and hypoxia. We try to avoid having patients become sick enough that they need mechanical ventilation, but occasionally they will present that sick initially. Priapism. So priapism is one of the complications of sickle cell disease that very few people like to talk about. The teenagers especially don't like to talk about it, but it is a problem, and so we do try to raise their awareness of it. Home management is usually oral analgesics, oral hydration, warm bath. A lot of my late teen, young adult boys talk about they just go exercise. I go do a couple push-ups. I kind of run around the house, and that seems to help prevent or resolve their episode of priapism. Sometimes we can do things to prevent it, like pseudoephedrine, leuprolide. If they have prolonged episodes, this can lead to impotence, difficulty urinating, some obstruction, and other problems in the future. So if it's prolonged more than 4 hours, we tell them they need to come into the ER. We do analgesia hydration. Oftentimes you need aspiration and irrigation with sedation. Acute transfusions have not been shown to be helpful. Again, the whole idea that the vasocclusion is already happening, that problem is already there, blood isn't going to fix it. Blood before it would have fixed it, but blood after it isn't going to resolve the problem. Like supposedly if you give a transfusion, the priapism is gone in 24 hours. That's a pretty long time to have priapism. When you can do an aspiration irrigation, it's resolved very quickly. Okay, so central nervous system complications and sickle cell disease. So these have by far been occupying a lot of our time research-wise, and also what we have a lot of data to think about how to prevent and treat these patients. So overt stroke. So our historical frequency is about 11%. We know that frequency has decreased because we have screening mechanisms now to identify patients at risk of overt stroke. Recurrence rate from a patient who had an overt stroke was 50 to 90%. We have methods of secondary prevention, which is chronic transfusion, and then primary prevention, meaning preventing that first overt stroke, which is also chronic transfusion with transition to hydroxyurea. Silent stroke, it's a little bit harder. You have to actually screen for it. Its frequency is about 20 to 40%. We're finding that they have increasing frequency as patients get older. So into their third and fourth decade, we're still finding these silent strokes occur. It causes neurocognitive and academic impairment. The primary prevention, we don't know what that is yet. Secondary prevention, you can use chronic transfusions. So the primary stroke prevention using transcranial Doppler ultrasonography, it's a great test, non-invasive, no radiation. We do it yearly between 2 to 16 years of age. There are defined cutoffs for normal, conditional, and abnormal. Normal don't need to be repeated. Conditional get repeated usually in about 3 months. Abnormal repeated right away. We can look at whether or not counseling those patients then about starting chronic transfusions to prevent their stroke. They have a risk of a stroke of about 10% over the subsequent 3 years after their abnormal TCD. Patients are put on chronic transfusions for some period of time. The Twitch trial came out a few years ago, which found that patients who are on chronic transfusions due to abnormal TCD, but who had never had a stroke or silent stroke or had no vasculopathy, could be safely converted to hydroxyurea with at least a 12-month overlap of chronic transfusions and not have an increased risk of stroke after they went on hydroxyurea. So those patients are not necessarily destined to be on chronic transfusions lifelong. For a patient who presents with overt stroke, so a sickle cell patient who comes in with a new neurologic symptom, it's really important for rapid triage and to do an exchange transfusion. Patients have the best outcome with an exchange transfusion. It's better than simple transfusion. This means involving your ICU to help you get the access that you need. And then once you've had the overt stroke, you go on chronic transfusion therapy or consider stem cell transplantation. The trial to look at converting these patients to hydroxyurea, called the SWITCH trial, found that they were it was not successful, and that the patients who switched to hydroxyurea did have an increased risk of stroke, and so we don't recommend that just yet. Okay, so long-term complications of sickle cell disease. So all of these individual acute complications cause end organ damage, which over a lifetime will accumulate in long-term complications. So the renal complications of sickle cell disease, you see this in our pediatric population. They have hypocynuria, they have a lot of enuresis, they have chronically dilute urine, predisposes them to dehydration, they have to pee all the time. We start monitoring them for albuminuria and proteinuria, and then later onset they'll have gross hematuria, a greater risk of end-stage renal disease as they get older. Okay, just a word on sickle cell trait. Your newborn screening pattern for sickle cell trait is FAS. So your main hemoglobin is hemoglobin A. Anytime you check a hemoglobin electrophoresis or hemoglobin analysis on this patient population, their hemoglobin S will be less than 50%. That is why they are asymptomatic. They have no clinical symptoms related or similar to patients with sickle cell disease. All of their hematologic parameters are normal. We don't consider it a disease, but it is a risk factor for certain types of complications. They seem to have an increased risk of microscopic hematuria. They can have renal papillary necrosis. They seem to have an increased risk of kidney disease, glaucoma, and splenic infarction. I had to laugh at a medical student last year who, after I did this lecture, he went skiing and came back and said, I had to go to the emergency room because I had a splenic infarct because I had sickle cell trait and I went skiing and I remembered you told me this could happen. So I thought, well, at least somebody was paying attention. So sickle cell trait is generally considered benign. There's been a lot in the news about this exertional heat illness or rhabdomyolysis associated with sickle cell trait. So it's exercise collapse associated with sickle cell trait. Most of the major hematology organizations have said that, there is not a need to screen patients, but that all athletes should be treated the same. We don't want to exclude individuals with sickle cell trait from physical activity or sports participation, but that everybody should avoid exercise when they're sick and dehydrated and should have appropriate warm-up and warm-down periods. There's also a very unusual cancer called renal medullary carcinoma. There's only about 150 cases reported and exclusively occurs in individuals with sickle cell trait. They looked at screening, putting a screening program on, but as I mentioned, 1 in 13 African Americans has sickle cell trait. You'd have to screen millions of people to prevent one, so it didn't meet the criteria for a good screening test. Okay, so we finished our sickle cell disease, and we're going to move into thalassemias, which are our quantitative hemoglobinopathies. So, some of the basic nomenclature. So we're primarily going to talk about the alpha and the beta thalassemias. So alpha thalassemia is a defect in your alpha globin genes, and your beta thalassemia is defect in your beta globin gene clusters. Clinical severity can be minor, which are typically asymptomatic, intermedia, which are not transfusion dependent but may intermittently need transfusions, and major, who have severe anemia and are transfusion dependent. So why does thalassemia cause problems? So if you remember, our hemoglobin molecule is beautiful in that it has 2 alpha globin and 2 beta globin, and they all match up, and everything's in balance because everything is made the right amount and everything goes together like it's supposed to. And so if you have either a decrease in the amount of alpha globin that's made or beta globin, then you're going to end up with an imbalance because one of the other beta globin that is not affected will be produced at its normal amount, and so you're going to have too many of one and not enough of the other. And the excess globin that is hanging out is the thing that precipitates and damages the red blood cell membrane. And that results in ineffective erythropoiesis. And so you have red blood cells that are damaged and lyse open within both the bone marrow and in the periphery. This leads to anemia. Expansion of the red bone marrow cells. You have extramedullary hematopoiesis because the body says, I need to make more red cells, and then I make all these red cells and they immediately fall apart, and so then I have to make more. And then you also have increased intestinal iron absorption because you're in a state of increased red cell production, and the body says, I need more iron to fulfill those red cells, because after the red blood cell, with the ineffective erythropoiesis, that iron has to go back through the whole system and be recycled to use in the marrow again, so the body thinks it needs more iron. Okay, so thalassemia. The thalassemias are much more common in the Mediterranean, as well as parts of Southeast Asia and the Middle East. The individuals in the United States with thalassemia, their families will have immigrated here from these areas where the thalassemia gene mutations first occurred. So thalassemia also can be diagnosed using some of those the hemoglobin tests that I had mentioned earlier, like hemoglobin electrophoresis and hemoglobin analysis and isoelectric focusing. One of the things that often comes up because the thalassemias can form a microcytic anemia is how to distinguish them between iron deficiency anemia, because those things may often be difficult to tell the difference between. And so in the patients with beta thalassemia trait, they tend to have normal to increased fetal hemoglobin and an increase in that hemoglobin A2. You may have remembered, I mentioned that like on the third slide, that is one of the minor adult hemoglobins, and so it is an alpha 2 delta 2. And so in a beta thalassemia trait patient, again, we're talking about balance. You have less beta globin and all the alpha globin that I need, and hemoglobin A2 involves alpha globin and delta globin. So that hemoglobin is increased because you have more of the alpha globin substrate available to bind with the delta globin. So that's why you see more of the hemoglobin A2. An alpha thalassemia trait, the fetal hemoglobin is normal and the A2 is not affected. And then in iron deficiency anemia, they're both normal. So the hemoglobin can often help you kind of identify beta thal trait. It doesn't always rule out alpha thalassemia trait. So first we're going to talk about the alpha thalassemia syndromes, and then we're going to talk about the beta thalassemia syndromes. So the alpha thalassemia, we have redundancy because we have 4 genes. And if you remember from, again, that fetal hemoglobin, or the prenatal hemoglobin curve, you need fetal hemoglobin very early in the development of the fetus, and which is why you have so many extra alpha globin genes, because if there's no alpha globin genes, you can't make fetal hemoglobin and it's not compatible with life. So if you have all 4 functioning genes, you're normal, you don't have anything to worry about. If you have managed to have 1 deletion, you're called a silent carrier. You are hematologically normal. The thalassemia traits, this is where it gets a little more confusing and complicated, because there are 2 methods to inherit your 2 gene deletion in the alpha thalassemias. You can have a cis deletion where the deletion is on the same allele, so your maternal, your paternal allele has both the deletions, or you can have a trans deletion where both the maternal and paternal are missing one of the alpha globin, and that primarily has relevance to genetic procreative counseling. And then there's having 1 functional alpha globin gene is hemoglobin H disease, and then you could inherit a mutated alpha globin for constant spring, which is also something that likes to show up on the boards. It's a slow-moving hemoglobin. It's one of those unstable hemoglobins, and for some reason it is often co-inherited in a mutation with a patient who has alpha globin deletions, and so it's hemoglobin H constant spring. And then, as I mentioned before, no alpha globin genes, no fetal hemoglobin, fatal in utero. Okay, so as I mentioned, so alpha thalassemia trait, you can have a cis or trans mutation. This is identified in the neonatal time period because of an excess in gamma globin. So again, we're talking about balance. So I don't have as much alpha globin, and therefore in my prior to birth and right after birth, I have all this excess gamma globin because my body is primarily making fetal hemoglobin. And the gamma globin tetramers are called hemoglobin Barts. It was discovered at St. Bartholomew's in London. That's why it's called hemoglobin Barts. These patients are microcytic. This again is neonates, so 80 to 95 is microcytic in a neonate. As they get older, their MCVs fall further, usually 65 to 75. These patients tend not to be as microcytic as the beta thalassemia patients. They will have mild anemia. Now, we talk about the hemoglobin Barts, and then we say, but wait a minute, as they get older, they don't make gamma globin, they're making beta globin. So what happens to the beta globin? So there is some excess beta globin floating around, and it forms a tetramer of hemoglobin H. But it's a very unstable hemoglobin, and so usually we can't detect it because it's in such a small volume in the alpha thalassemia trait population, because they still have 2 functioning alpha globin genes. So sometimes this is mixed diagnosed and treated as iron deficiency anemia. So this is where I want to talk a little bit about that cis and trans deletion, because this is like one of those things they like to show on the boards where they say, this baby, here's this baby's test. Which parent which one of these is his parents, where they try to figure out how did the baby end up with that particular hemoglobin diagnosis. And so if both parents carry a trans deletion, so that means that they both themselves have alpha-thal trait, but they have trans deletions, then all of their babies will basically have the same type of thalassemia trait as they do, and there's no risk of thalassemia major. If both parents carry a cis mutation, then they have a 25% chance of the baby inheriting no functional alpha globin genes, and they will have alpha-thal major or hydrops fetalis, which is fatal in utero. And so when you have individuals with cis deletions, the procreative counseling is a little bit different for them because they do have a risk of a life-threatening hemoglobinopathy. Okay, so hemoglobin H disease. So then this is the situation where the infant only has one functioning alpha globin gene. So if I go back, if this person and this if this person and this person had a baby together, so if you had these parental alleles, then you could end up with a baby with one of the alleles completely deleted and the other one with one functioning alpha globin gene. So these patients also have hemoglobin BARTs, but they also make hemoglobin H, and it's a much higher amount of it, so oftentimes we can identify it. It is a fast-moving band as opposed to the constant spring, which was a slow-moving band. They have moderate to severe anemia. They are very microcytic, MCVs in the 50s to 60s. They will often have hepatosplenomegaly, and they'll have little hemoglobin H inclusions, as I show over here, when you stain their red blood cells especially. There's a lot of phenotypic variability. I've only had one or two of these kids in my practice, and one of them never needed any transfusions, and one just needed one when they were sick. You do have to monitor them for hemochromatosis, though, due to the increased intestinal iron absorption, even if they're not receiving blood transfusions. And then, as mentioned before, the homozygous alpha thalassemia. It sometimes can be identified. There are cases where it has been identified and the family has been offered in utero transfusions, and there have been a couple of children delivered and then received postnatal chronic transfusions or stem cell transplant after birth. And so there are surviving individuals who were born with homozygous alpha thalassemia trait, but that is only something that is available to us in a third world. I mean, in a first world, not in a third world, where the bulk of this disease is happening in Southeast Asia. They don't have access to that type of care. Okay, now let's move on to beta thalassemia. So this one's a little bit, we used to say it was more straightforward because, hey, there's just two beta globin genes. But then they throw in these beta pluses and these E's and stuff like that, so it starts to look just as complicated as the alpha thalassemia patients. So beta thal trait. So the reason why there's a plus and a 0 kind of relates back to the sickle cell, sickle beta plus and sickle beta thal null that I talked about. So beta null or beta 0 means it's deleted. That beta globin gene is deleted. It's just not there. There's anything related to it. Beta plus means that the mutation in the beta globin gene is some type of point mutation, missense, truncated. So there's some hemoglobin A production, but not the normal amount. There's abnormal production of hemoglobin A because that beta globin gene is not as functional as the normal one. So that's why there's a beta plus, which also means there can be a lot of variability because I've seen these beta pluses make anywhere from 8% hemoglobin A to 35% hemoglobin A. So you can imagine there'd be a lot of variability in the clinical scenario or clinical phenotype based on such a wide range in hemoglobin A production. But beta thalassemia trait patients have normal blood counts. You cannot detect this on newborn screen. So it's usually identified as they get older when they start having some hypochromia and some microcytosis. As they get older and you do their hemoglobin electrophoresis or hemoglobin analysis, you'll find that elevated hemoglobin A2. Sometimes they have slightly increased fetal hemoglobin. It's very common. It's frequently misdiagnosed and treated as iron deficiency anemia, and it's inherited, so obviously you can pass it on to your offspring. So beta thal intermedia gets a little bit more complicated. So this would be someone who inherited beta plus mutations from both parents, a beta plus and a beta null mutation. a hemoglobin E mutation and a beta plus, a hemoglobin E and a beta null. So this is like E beta null thalassemia, E beta plus thalassemia, and then we would call these thalassemia intermedias. Now, sometimes it's difficult unless you do like the beta globin sequencing, which I'm having more and more trouble getting done a lot. Some of the companies that used to do it aren't doing it anymore. So sometimes it's more of a clinical diagnosis, especially because these patients may be very, very mild, especially the beta plus, that you can't really distinguish them from a traditional beta thalassemia trait patient. So as neonates, they have normal blood counts. They may have mild to moderately severe anemia. Again, some of these patients may have more severe. The ones who have hepatosplenomegaly are going to be on the more severe side. Some may require intermittent transfusions, and just like the hemoglobin H patients, you have to monitor them for iron, increased iron absorption and hemochromatosis, even if they are not on transfusions. Okay, beta thalassemia major. This one's a little bit more straightforward. You have inherited no functioning beta globin genes. So at birth, your blood counts are normal because you're making fetal hemoglobin, and that's what your body's doing, and so it looks great. On newborn screen, it is detected because they make only F. All newborns at term should have F and A at least, and so if it's F only and there's no functional A production, then that's consistent with beta thalassemia major. And so you can see on this peripheral smear, you have these very pale, very hypochromic, lots of different sizes, some these very sort of ghost-like images, and nucleated red blood cells. So it's a progressively severe anemia during the first year of life. If it's not intervened, they will have organomegaly, growth failure, and will develop what we call the thalassemic facies. Because hematopoiesis in our first few years of life include our skull and our facial bones, as they try to make red blood cells to make up for the fact that they're so severely anemic, they'll have expansion of the marrow cavities of the face, and they'll have the facial changes. So they are placed on lifelong transfusions or bone marrow transplantation if available, and then you have to monitor for them hemochromatosis. So the primary therapy for thalassemia intermediate, that's transfusion dependent, or for thalassemia major. So again, they are cured by stem cell transplant. So those with HLA matched sibling donors, we send a transplant. Those without, then we consider transplanting them on a trial. Chronic transfusions. So unlike the sickle cell patients where I'm just transfusing them to get their hemoglobin S to a certain point, in thalassemia, you have to hypertransfuse them. You have to shut down their marrow. So it's different transfusion parameters than you would normally think. So they often get transfused every 2 to 4 weeks, and you want their nadir hemoglobin to be 9 to 10. I know no other place in hemonc are you like giving somebody with a hemoglobin of 10 more blood, but you're doing that because you want no erythropoiesis whatsoever, because that's one of the things that contributes to some of the disease manifestations. So your goal is you want to alleviate the symptomatic anemia, you want to suppress the interactive erythropoiesis, you want to prevent the bony complications, and you want to improve their organomegaly that they will have and improve their growth and development. But all of those transfusions will definitely cause iron overload. Sometimes they'll develop hypersplenism, they'll have a lot of iron loading in their spleen, and they may need to have a splenectomy. So there are great guidelines for our thalassemia patients that are on chronic transfusion therapy that we have to follow. Many of these guidelines that start around age 10 are related to the iron toxicity they get from their blood transfusions. We have to monitor them for endocrine conditions, the hepatic iron and cardiac iron that will start to develop, as well as complications of regular blood transfusions, alloimmunization, transfusion-transmitted infections, HIV. Families still have those kinds of fears when you're talking to them about starting their child on chronic transfusions. Okay. So the last main thing I'm going to talk about is transfusion iron overload, because it relates to both the patient populations I talked about. So I know you've already had you've had a lecture related to iron accumulation and hemochromatosis, but the blood transfusions increase our iron stores. The capacity of transferrin is exceeded. You have unbound iron, which accumulates, and it accumulates in our organs, specifically the liver, the heart, the pituitary. It can also accumulate in the skin. I've had a couple of refugee patients come in over the years from overseas who were transfused and never chelated, and they kind of have this greenish tinge to their skin because they have iron deposition in their skin. And so the free iron radicals can be very damaging to the tissues and lead to cirrhosis, cardiac damage. So organ accumulation of iron. So liver will cause cirrhosis, liver failure. There's a risk of hepatocellular carcinoma once the cirrhosis has happened. In heart, you'll have heart failure, dysrhythmias, sudden death. The pituitary, hypogonadism, hypothyroidism, you can have significant hypopituitarism after iron deposition. Pancreas can have diabetes, parathyroid glands, hypocalcemia, and then as I mentioned, the skin will cause hyperpigmentation. So how do I diagnose iron? Well, so first of all, we know that we've iron loaded the patients. After you've had about 100 mLs per kilo of packed red cells, or about 10 blood transfusions, you are iron loaded. We kind of know that we're doing this to patients. We can use the serum ferritin. It's an indirect measurement. It's not great. At the lower levels. I had a kid last week that his liver iron measurement on his MRI was normal, but his ferritin was still running about 900. So you can see they don't always match up. So when we get to the lower levels, we have to use multiple modalities to continue to know whether or not to treat them. Liver biopsy. So, my patients always loved when I said, hey, you're due for your annual liver biopsy. So, it was not it's still considered actually I'm not even sure that it's the gold standard anymore. For a long time, liver biopsy was the gold standard. We will occasionally do liver biopsies before more invasive things such as bone marrow transplant to really get a good assessment. Patients I have who come from overseas, we definitely, because we want to grade their degree of cirrhosis. But for our patients that we're starting and we're managing up front, we'll often do MRI imaging to be able to detect the iron in the liver. So how do we treat iron overload? So we can chelate the iron, and we have a variety of options for chelation. For some conditions, like our sickle cell patients, we can do red cell exchange. When we do either manual or automated exchanges, that involves removing a certain mass of red cell and giving them back new red cells, so we can get their net negative iron loading. Sometimes that can be more difficult because of access. If you're going to do automated, you have to have a way to remove the blood and a way to give the blood back, so you need two sites of access, which can be more challenging in our younger kids. And then for some patients who either respond really well to hydroxyurea or they undergo bone marrow transplant and then they have normal hemoglobins, we can manage their iron overload with phlebotomy. So there are a few iron chelators we can choose from. There used to be just one, so the fact that we have three is pretty amazing. There are two oral iron chelators. Deferricerox is an oral solution. Taken once daily. Its main toxicity tend to be GI, some GI upset, and hepatic transaminitis. I've had one or two patients who haven't been able to tolerate it because it makes their LFTs go up. We have to monitor it monthly. It's been a pretty good oral chelator. Deferriprone was more recently approved here in the U.S., though it's been in use overseas for a long time. It's tablets. It's 3 times a day instead of once a day, but it is a tablet you can swallow as opposed to a liquid that you drink, though deferricerox is now available in tablets as well. And its main toxicity that you get warned about all the time is neutropenia. Sometimes, so they recommend weekly CBC, so you can imagine how many kids want to come in weekly for a CBC while they're on deferriprone. Not that many. Most patients, I think, choose to be on deferricerox because it's once daily and it doesn't require as much monitoring as the deferriprone. Then we also have IV subcutaneous chelators, deferoxamine. Patients can give it to themselves at home as a sub-Q infusion. I remember as a fellow, I met a 17-year-old sickle cell patient who had no iron loading, who had been doing his sub-Q Desferal infusions at home for like 8 years after his stroke, and we all thought he was amazing because he was actually willing to do a 10-hour sub-Q infusion 5 nights a week and did it religiously so that he wasn't iron loaded. We have to monitor these patients for ear complications. They can audiograms because it can affect their hearing. They have to have regular eye exams due to risk of cataracts, and then we have to monitor their bone health due to risk of osteoporosis on chelators. Sometimes in patients who have really severe iron overload, there are protocols where you actually use combination chelators. Patients who have severe cardiac iron loading, so that they're having cardiac abnormalities, dysrhythmias, or abnormal function, they'll often be hospitalized and treated with 2 chelators to try to rapidly chelate the iron out of the heart so that you can have resumption of normal cardiac function. Okay, other hemoglobinopathies. I was going to primarily save this for you guys to look at on your own, but I'll just mention hemoglobin E. I've talked about it along the way, just to kind of reinforce that there's always seems to be hemoglobin E questions on the test. It's a beta globin mutation, so just like the other beta globin mutations, you can carry 1 copy of hemoglobin E and have hemoglobin E trait. Now, when you have hemoglobin E trait, you do have microcytosis. So unlike sickle cell trait, which is hematologically undetectable, patients with hemoglobin E trait will have microcytosis. You can measure hemoglobin E. I showed that to you with the hemoglobin electrophoresis. Hemoglobin E disease means that you've inherited EE, and those patients have mild microcytic anemia and target cells. They're asymptomatic. There's not a whole lot. They don't need transfusions. They're otherwise healthy. It's when patients with hemoglobin E inherit a thalassemia, co-inherit a beta thal or beta plus mutation, that they can look like a beta thal intermediate or major. So these would be hemoglobin E patients who are significantly anemic and microcytic are not going to have E trait or E disease. They're going to have an E thalassemia. So if they give you some hematologic parameters and there's some hemoglobin E and they're really anemic and they're really microcytic, it's not going to be EE disease or E trait. Let's see. So I was going to save the rest of these for you guys to look over on your own, because they may or may not be, they only have a certain number of tests, the questions they can put on the test, so there may end up not being one on these, though they can occasionally show up. All right. Thank you, and I think we may have finished. It's 11 o'clock. Hey, I think we might actually almost be back on schedule.